Cool. All right. So we learned all about shock, right? Chris went through everything, and now we're going to talk about bleeding. If we're talking about shock in conjunction to bleeding, what type of shock do you think we're really talking about? Hypovolemic, right? So we're losing that blood volume, right? We got low amounts of water. So depending on the type of bleeding we're going to be dealing with is going to kind of dictate how quickly hypovolemia will set in, right? I'm sure everybody in here at some point in their life has cut themselves and they've not gone into shock, right? So, well, clinical shock, right? So we'll talk about different types of bleeding, different injury patterns, and which ones are probably going to be the ones that we got to get ahead of fairly quickly, okay? So with bleeding, the first thing we got to do, always, most important thing for us, recognize it. Because if we don't see it, we don't know if it's happening, right? Now, is all bleeding visible? No, right? Internal bleeding, we'll talk about that. We'll talk more about that next week when we get to like abdominal injuries, chest injuries, things like that. Okay, and then understanding how bleeding affects our body. Remember, it can be internal or external. And then bleeding can cause weakness, shock, and death, okay? Think about blood in our body as kind of the, not fuel, but it provides the fuel, right? The oxygen, the sugar. So if we don't have enough blood circulating, we're gonna start having drops, right? So that weakness is not an uncommon thing. Syncope or passing out, not an uncommon thing. Dizziness, not uncommon, right? That's all blood leaving the brain, not perfusing. So one of those things, just don't be shocked if you see it. A little AMP, so cardiovascular system, right? We talked about it. Circulates blood to our cells and tissues, pumps, pipes, fluids, right? So the three parts of our shock triangle there. Carry away our metabolic waste product, and then responsible for supplying and maintaining adequate blood flow, right? And it does this kind of by different variables, as we saw, right? We can have vessel changes, we can have heart rate changes, we can have stroke volume changes. There's all sorts of variables that we got to kind of keep in mind, okay? And then, like I said, there are three parts: pump, pipes, fluid. So pump, container being, or the heart, container being the blood vessels, and then the fluid being blood. Now, we'll talk about arteries and veins a little bit. How's everyone feel about their human body, the anatomy stuff? I know it's a lot, right? We threw fistfuls at you. This is going to come up again a little bit today. We'll talk about some clarifications on that. I know we did the bucket thing. If you're someone who needs something to rationalize too, do I have anyone in here who's like worked on sprinklers before pretty extensively? Think of it like that. That's what always helped me. Pumps, pipes, fluids. Fluid being your water for your sprinklers, pipes being the sprinkler lines, and then your pump being your pump, right? So if you're gonna have to diagnose that if you see water in your yard, right? So it's kind of the same idea. So there's another way you can rationalize it, but that obviously was a really good visual interpretation. So the heart needs a nice, rich, and well-distributed blood supply, right? So our heart is kind of a selfish organ. It has to be, right? It's the pump, it's the motor that keeps us going. So the blood will actually, or the heart rather, will get its blood first. And you'll talk about that when we get to cardiovascular a little down the road. There's a little section of the aorta that actually feeds the heart itself, because like every other cell in our body, it needs the fluid, or excuse me, the blood, which is providing our oxygen, sugar, and then waste removal, right? The three big things for perfusion. Our heart works as a two-paired pump. So we have an upper pair and a lower pair, right? Our atria at the top, ventricles at the bottom, and then we can further split that into a left atria, left ventricle, right ventricle. I would heavily recommend learning how that blood flows through, because if you understand how blood flows through, you're going to understand when things start going wrong. We can identify, okay? And then blood leaves each chamber through a one-way valve. Has anyone ever heard of heart murmurs before? That's a pretty common thing, especially with like kiddos, when their heart's still developing. Not uncommon for them, their one-way valve to leak, and that's the sound that you'll hear. It kind of sounds like a washing machine tumbling when you hear those, okay? But everything is a one-way valve. We do not want blood going backwards. Blood needs to continue to trend forward or it's not usable for us, right? So if we talk about how blood enters the heart, our deoxygenated blood returns back to the heart via the vena cava, or vena cava, right? So we have our superior and inferior vena cava here. Those will feed into the right atrium. The right atrium contracts, sends blood to the right ventricle. Right ventricle contracts, sends it out through the pulmonary arteries. Now this is where things get tricky. Is that blood oxygenated? No, right? What kind of blood do arteries typically carry? Oxygenated. So this is the one time, there's another one with babies in utero, but we won't talk about that. This is the one time that you need to know there's a flip-flop, okay? As long as you remember arteries are away, veins are towards, in conjunction to the heart, you'll be just fine with that, okay? And so out through the lungs, we have the oxygen exchange via diffusion there. And then with that next pump, blood will return via the pulmonary veins to the left atria, contraction, left ventricle, contraction, out the aorta to the rest of the body, okay? Now, also understand it's not going to be broken down like contraction, 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 right, to get everything moving. These two are moving at the same time. These two are moving at the bottom at the same time, right? So it's uppers, lowers, uppers, lowers. Upper atria contracting to the ventricles at the same time, ventricles to the lungs and body at the same time, okay? So lub, dub, lub, dub. Questions on this so far? Okay. So our blood vessels, so remember arteries are always away. That's kind of the bar none. You need to know that. Don't just base it on the type of blood it carries, because that's when you're going to get tricked up, especially when we talk about the pulmonary circuit there. But arteries carry blood away. Now remember with capillaries, are capillaries isolated to just our alveoli, or do we have them everywhere? Everywhere, right? Everywhere in our body has capillaries. And then for your guys' knowledge, how small these capillaries become, even these arterioles, can we see our blood cells, red blood cells individually if we just look at blood? No, right? These are so small that they're actually moving groups of 1 to 2 blood cells at a time through them, okay? It's a fairly thorough process. We got to make sure, our body needs to ensure that it's getting all of the oxygen possible from our red blood cells, right on that hemoglobin. But arteries will carry out away from the heart. As they get narrower, they become arterioles, right? So that's kind of the landing pad or the freeway exit getting ready to go to the capillary, okay? So small arterioles, smaller vessels that connect the arteries to the capillaries. And then from there, those capillary beds, they pass among all the cells and link arterioles and venules. So those capillaries, what's the big process that happens in those capillaries? Perfusion. Can we break that down a little further? Yeah, the oxygen CO2 exchange, right? Not entirely wrong, but yeah, that we get that oxygen CO2 exchange happening in capillaries everywhere. Remember, there's trillions of these in your body, all over, okay? So we have that gas exchange. Now we need to go back to the heart. We've dropped off all our oxygen, picked up all our CO2. We got to get rid of this waste so we can resupply, okay? So from the capillary, it'll go to a venule. So it's that connector between the capillary itself and the vein. Okay, so very small, thin-walled vessel that empties into the veins, and then moving forward to veins themselves, they carry the blood back to the heart. So everyone's seeing how these work with each other. Okay. Now, oxygen and nutrients pass from capillaries, into the cells, and then waste and carbon dioxide will diffuse into the capillaries. Okay. Remember diffusion. Can someone give me a definition of diffusion? From an area of what to what? High concentration to low concentration. Everyone feel like they have a grasp on that. Okay, if you're someone who was a little unsure, look at a couple of your faces seemed a little unsure. The way I always thought about diffusion, area of high concentration to an area of low concentration. So let's go to imagination land for just a second. Imagine you're at a concert, right? You're shoulder to shoulder, it's a packed show, it's your favorite band, whatever, right? You're shoulder to shoulder, and then you see the light come down, the angels start singing, and you see that big circle right in front of you with no people. What's the first thing you're probably going to do? Probably going to step right into it, right? You're going from an area of high concentration of people to an area of low concentration people because it's easier, right? It makes it easier to maneuver. Our body does the same thing. Nature is kind of inherently lazy, okay? It doesn't like to work super hard, which we'll talk about when we get to like CO down the road. Okay, but remember, that's how we do this process. Those oxygen molecules, when we take a breath, they come in and they say, man, I'm around all these oxygen molecules. I'm sick of being around these guys all the time. I've known them forever. And then they look through that capillary membrane into the arteries, or from the alveoli to the capillary, and they say, oh, there's no oxygen over there. They stepped through because there's no oxygen. Well, at the same time, CO2 is having the same thought. That's how our exchange works. Okay, now the happenstance will follow each other around, okay? Well, we obviously don't exhale most of the oxygen just because a couple molecules jumped, but that's how that process works. So keep that in mind. That is one that they love to throw out there. Diffusion, area of high concentration to low concentration. Everyone feel like they get that concept a little better? Okay. So our blood has a few very important things in it, each one having differing jobs. First one is our red blood cells. Let's throw a little bit of a quiz out here. Can someone tell me in med term, what is red blood cell? Starts with an E, I'll give you that. Yeah. Erythrocyte, yeah. Red cell, erythrocyte. So our red blood cells, responsible for the transportation of oxygen to the cells and CO2 away from the cells to the lungs. Does anyone know, or can someone tell me, what is the compound on our red blood cells that holds the oxygen? Hemoglobin, right? So when we get an SpO2 reading, we're reading how full the hemoglobin is. I'm going to say it again. SpO2 reads how full the hemoglobin is. Based on my statement right there, did it tell you what gas it's carrying? No, right? That's where carbon monoxide becomes dangerous, because you can have someone who's been around exhaust or been in a burning house. You're going to check their SpO2 and it's going to say 100%, because inherently, once again, nature's lazy. With the oxygen we breathe, can someone tell me the chemical compound for oxygen? It's O2, right? So there's 2 oxygens. If we talk about CO, carbon monoxide, there's 1 oxygen. So our hemoglobin says, I can either carry 2 of those bad boys, or I can just grab 1, and that'll be way easier. So carbon monoxide has a higher affinity to binding to our hemoglobin than oxygen, which is why SpO2 cannot always be a reliable vital sign, right? Read the situation, read your patient, not just that room, okay? That makes sense. Everyone see the job of the red blood cell. Carry that oxygen, get rid of our CO2. Now the next one, white blood cells. Can someone tell me what the med term is for that one? Leukocytes, right? Leuko, white, cyte being cell. Yeah, our white blood cells, they fight infection, okay? They also are kind of responsible for pulling away the dead cells that have, like the white blood cells that have died fighting the bacteria or whatever infection we have, okay? Now our platelets are responsible for forming clots. Now, platelets work in conjunction with our red blood cells. What they do is they break down our red blood cells just enough where they become sticky, which is why you get scabs, right? That's all red blood cells that have been broken down and stuck together. And then last but certainly not least, we have plasma. Plasma is the vehicle that carries the cells. It is what makes your blood wet, which is why you can donate just plasma. They'll centrifuge that out, give you the cells back, but they'll keep just the fluid portions. Okay, and they'll use that plasma for like trauma cases to bring back blood volume instead of fluid, like Chris was talking about. As a medic, we can give IV fluid. A lot of times they'll use plasma instead, a little bit easier on the body. New science is saying, which, you know, stick to the NRMT, what the questions they ask is going to be the stuff we're presenting, but new science is showing that red blood cells actually don't carry CO2 away. It actually diffuses into that plasma. Fun facts. Now, as far as NRMT is concerned, remember, it's always red blood cells, but things are changing. So don't be shocked if you see that in the next few years, they're releasing that, CO2 is carried by plasma. Okay, now blood clot formation depends on a few different things, right? We don't just want blood clots forming willy-nilly, because then we'll run into issues like MIs, PEs, strokes, and we'll talk about those at great lengths down the road, okay? But first thing, blood stasis. What does stasis mean? Static. What would static be? Not moving, right? So stasis, static, not moving. If we're not moving, blood starts to coagulate. Those platelets start to make that blood sticky, okay? Which is why we start to see things like clot-related issues in folks who live sedentary lifestyles. People think about the old folks that live in that chair. They're gonna live and die in that chair, right? It's because they're not moving. Even just moving around, me walking right now, muscle contraction helps to push blood forward, okay? So if we start becoming static and we don't move a whole lot or sedentary, we run the risk of forming clots. We can have changes in our blood vessel walls, okay? We can have some constriction or dilation that's gonna start affecting that, okay? And then depends also on the body's ability to clot. There's all sorts of conditions out there that affect clotting. Can someone tell me one off the top of their head if they know it? Starts with an H. Hemophilia. Yeah, we'll talk about that here in a bit. Hemophiliacs can't clot. They don't. There's other things outside of platelets that help with clotting in our blood. There's clotting factors, which hemophiliacs are missing one of the clotting factors. But yeah, these people just don't clot. So things like a bloody nose or even a paper cut can actually be genuine life threats because they just don't stop bleeding, okay? But there's tons and tons out there as far as different platelet or clotting disorders go. And now when tissues are injured, platelets begin to collect at the site of the injury, right? So we injure ourselves. That's the body's response of, okay, we need to start sending healing factors being carried in our blood, right? So the platelets will show up with those red blood cells. They'll start to break down the red blood cells. They start to grab onto one another, and they form that clot, which will eventually become scab, and then the healing process can begin once we've self-sealed that off. But we can't always seal every injury, right? Some injuries, depending on the type of bleeding, we're gonna need a little bit more outside help, okay? And we'll talk about that. So, autonomic nervous system, just from the jump, do we control this? No, automatic, right? So the autonomic nervous system monitors our body's needs, okay? Helps adjust our blood flow. So we have the dilation and constriction of our vessels normally. Constriction brings pressures up, dilation brings pressures down, right? So our body will just kind of manage itself, try to keep that homeostatic line, homeostasis, okay? Will automatically redirect blood from other organs to the heart, brain, lungs, and kidneys in an emergency. Fun fact, these are all of our organs are important to us, but all of these 4 are necessary to life. Your kidneys actually carry a lot more weight than people think as far as keeping you alive. Kidneys help with blood pressure management, right? That's a big one that a lot of people don't know about. Fluid retention and fluid management obviously goes to the kidneys, but all of these are incredibly important that need to be kept alive, because if they don't, we tend to develop a case of deadness fairly quickly, okay? Now, does anyone know what this process is called? Redirecting blood to more important organs. Starts with an S. Shunting. Yeah, shunting. Kids do this really, really well. If you ever look at a baby who gets cold, they pull their hands and their arms and feet will get really pale really quickly because they pull all that blood to those important organs inside. Now, adults will also do this, especially in situations of big trauma, okay? And then these will adapt to maintain our homeostasis and perfusion, right? We're matching cellular demand. Perfusion is meeting cellular demand, oxygen, sugar, waste removal, okay? Questions on the autonomic nervous system at all? Okay. So a little pathos. So perfusion, once again, the circulation of blood within an organ or tissue to meet the cell's needs for oxygen, nutrients, and waste removal. Those 3 things have to happen for us to meet perfusion. If we do not have them, we're not perfusing. If we're not perfusing, cells start to die, okay? And we'll see why later down the road that can become pretty detrimental to our living status, okay? Now, speed of blood flow. It really depends on the situation, right? We don't want to keep that heart rate of 60 if we're going to be going out and sprinting or running long distances, right? Because we're not going to be able to perfuse to keep up with the rate of cellular demand, especially our brain, okay? So it has to be fast enough to maintain circulation, but slow enough to allow cells to exchange that oxygen, nutrients, and CO2, right? That diffusion. So there's kind of a nice balance to it. That's that homeostasis. Homeostasis is just natural balance of our body. Okay? Now, some tissues are going to need constant blood supply, while others can survive with very little. Our skin does not need as much blood to survive as our heart, right? There's kind of an order of importance. There's a pecking order of sorts when it comes to the organs in our body and which ones are better at surviving and which ones aren't, which ones are needed for survival, which ones can wait, right? If, for example, a bear walked into this room, do you think it's important that my bowels can start digesting food? Probably not. You might have a reaction with your bowels of sorts, but it's not the most important process, right? We need our heart to start pumping faster. We need our lungs to expand so we can breathe better. We need our muscles to be provided with blood or perfusing. That way we can run or fight, right? There's a difference in an order of importance just depending on the situation, okay? Now, all organs and organ systems, once again, depend on adequate perfusion to function properly. If the cell's demands are not being met, then they will start to die. And remember the building of tissue, right? Cells become tissues, tissues become organs, organs become organ systems. So it all starts at the smallest little building block. And if we start to lose those building blocks underneath, it's like if you're playing Jenga and you start taking the ones out from the bottom, everything topples over, right? You got to make sure the cells are supplied. Now, death of an organ system can quickly lead to death of a patient. Depending on the organ system will dictate how fast that happens, right? If we have cells in our heart that are dying, or cells in our brain that are dying, or cells in our lungs that are dying, we might start to see decompensation a lot quicker, right? Versus cells in the skin or, in our bowels. And then emergency care supports adequate perfusion until the patient arrives to the hospital. Burn that into your brain. Every single thing we do in this job, medical or trauma, comes back to perfusion. Are we missing perfusion? What is one of the pieces we're missing? If we find it, we got to fix it, right? To the best of our ability within our scope, okay? And then the heart requires, once again, a constant supply of blood. It is the motor or the engine of our chest, our body. If we do not have that functioning, we don't survive. Questions on patho or perfusion at all? It's pretty straightforward stuff for the most part. Okay? So, external bleeding. Another way we can say bleeding, hemorrhage. So don't be surprised if you see hemorrhaging or hemorrhage. We're talking about bleeding. And remember, external bleeding is visible bleeding, okay, or visible hemorrhaging. Anytime we can see it, it's an external wound, okay? So, depending on the location, depending on what vessels are affected is going to dictate how serious this is going to be. With serious external bleeding, it may be difficult to tell the amount of blood loss, right? You guys all saw that water on the table, right? A little bit, it can look like a lot. Now imagine someone bleeds 2 liters onto a linoleum floor. That's gonna look like a bloodbath, right? Keep that in mind. And then try to estimate. That's the purpose of that. If you can walk into a room and kind of have an estimation, okay, they may have lost upwards of half a liter or a liter of blood, that's gonna maybe kick your brain into overdrive. Okay, we need to move faster. Or okay, we've got time to settle down, okay? And it's not always easy. There's one call in particular that I think of, that a gal fell down, hit her dome on the floor pretty good, and when I walked in there was like blood smears on the wall, there's blood everywhere. You would have thought she got murdered in there. It was all from a little cut on her head. She just happened to be moving and had blood on her hands, right? So it can be difficult to estimate that sometimes. Keep that in mind. You just got to do your best. Another one is childbirth. It's super normal for women to lose upwards of 12 ounces of blood when they deliver a child. You want to know, is that a normal amount of blood they're losing or not, right? So spend time in it. If you have to pour some water on your floor, pour some water on your floor. Will you hold your can up, actually? So that is about how much blood a woman will lose, potentially, or can lose when it comes to, you're good, childbirth. Just keep that in mind, okay? And then the body will not tolerate a blood loss greater than 20% of their total blood volume. Does everybody have the same amount of blood in their body? No, so it's gonna look a little different for everyone. The range is 5 to 7 liters, okay? 5 to 7 depending on the size of the person. So if we just kind of conglomerate or find the median there, it's gonna be 6, right? Average is about 6 liters, but 5 to 7 is your range depending on the size of the people, okay? That's why it's a percentage, right? There's no set volume amount. Everyone tracking that? Okay. So changes in our vital signs, right? If we have significant blood loss, we already kind of talked about it, or you talked about it with Chris with shock, right? We have an increase in heart rate, right? If we start losing too much volume, the body says, ooh, I know what I can do instead. I'll supplement quantity for quality. I can't give you 12 good beats, but I can give you 24 okay beats, right? So it starts to try and adjust its different methods to getting it through. You might start seeing an increase in respiratory rate. We're not getting enough blood circulating, meaning we're not getting enough oxygen circulating. So maybe they're gonna start breathing faster. Let's just hyper-oxygenate the blood that we do have. And then last but not least, we have that decrease in blood pressure. Is that an early or a late sign in shock?
Late.
It's a late sign. Shock is really hard to identify. Did you guys kind of come to that agreement? Shock is a tough thing to really see. It's hard to see when it becomes irreversible, especially in our circumstances, right? We don't have the labs, we don't have the imaging to tell you how bad something's bleeding. We just gotta figure it out, right? So trust your gut. If you see a low blood pressure, traumatic situation around them, let's just start moving, especially a low blood pressure with a high heart rate. We're starting to see that compensation happening. Now, how well people compensate for blood loss is related to how rapidly they bleed, right? If someone has a slow bleed, like we all saw, right? It's very manageable. We can scoop that water back in and we can keep us at that perfusing line. But if we're bleeding, excessively, we're starting to hit hypovolemic shock, that's where we start to run into problems. So an adult can comfortably donate 1 unit of blood over 15 to 20 minutes. Like Chris said, that's so that our body can manage, right? We can maintain perfusion, maintain homeostasis as long as it's over a prolonged time, especially with how small those needles realistically are, okay? If a similar blood loss occurs in a much shorter time, that person may rapidly develop symptoms of hypovolemic shock, right? So if someone has arterial bleeding or they have an internal solid organ rupture, they can lose a lot of that blood internally very, very quickly, right? We all saw when he opened up without the hose and started dumping water, right? I know you saw it. You saw all that, all that water dumping out, right? That's going to enter that hypovolemia very, very quickly, okay? And then other factors, consider age and pre-existing health. When we talk about old people with pre-existing health conditions, what is a medication that might make this a lot harder for us to manage? Or medication type? Blood thinners, right? Blood thinners, we are giving people medications so that they don't form clots. Usually people who have had heart attacks, strokes, pulmonary emboli in the past, right? But there are things to consider, or even just older people in general, right? Our bones can bleed, fun fact. You can lose, I might write this one down, you can lose upward of 1 liter of blood per femur. You can lose upward of 1 to 2 liters of blood from your pelvis. So if someone gets ran over, right, their pelvis is Legos, their femur is Legos, there's a chance they're losing 3 liters of their own blood inside of that space, into the abdomen, into the thighs, right? That's not even counting external if it's open, okay? We can lose a lot of that blood very, very quickly. So with older people, osteoporosis. Can someone tell me what osteoporosis is? It's weakened bones, right? So their bones are a little bit more fragile, a little more frail. So if they fall down, it's not uncommon for them to fall and break a hip, right? If you think about an old lady complaint, the first one that should come to your mind of trauma is usually, I broke my hip, right? Well, that's femur or pelvis involvement. So we already know from the get-go, the likelihood of them bleeding internally is pretty high, just based on the complaint. Does that make sense? Okay. Any questions on external so far? Okay. So characteristics of external bleeding, right? So serious conditions with bleeding. So significant MOI. What's MOI stand for? Mechanism of injury, right? Very good. And then patient has a poor general appearance and is calm. They're kind of finding their solace in that moment. They're finding their peace with God of sorts, right? They are to the point where they've bled so much, they're pale, cool, diaphoretic, but they're not panicking anymore. Their body is starting to roll into the death a little bit. We can start seeing signs and symptoms of shock. So depending on what type of shock is obviously going to dictate those. Significant blood loss or rapid blood loss, right? So significant being total volume, rapid the speed, right? As we just kind of talked about a couple slides back, right? How fast they lose that blood and how much they're losing is going to be a big portion of this. And then uncontrollable bleeding. If their body is not able to clot it, they're not able to compensate. Even for us, applying pressure with bandages, we can't get it to stop, right? We got to get the bleeding under control. That's our bread and butter. That's what we are good at in this field, okay? So when it comes to the type of vessels and their bleeding, we got a few different ones, okay? Arterial bleeding. So pressures cause blood to spurt and make bleeding difficult to control. Why do you think arterial bleeding spurts?
It's just a contraction.
Yeah, as that heart contracts, you're seeing every contraction of the heart. If I cut my hand off, every time my heart beats, you're going to see a spray of blood come out. Right? Now, typically brighter red and spurts with the pulse. Why do you think it's brighter red? Yeah, very good. It's oxygenated. Yeah, arterial bleeding is dangerous because it's oxygenated blood, so we're losing a perfusion segment, right? And then on top of it, it's harder to control because the heartbeat, it's spurting every time. It's connected directly to our cardiac system, okay? Versus venous bleeding, it's more of a dark red. Flows slowly or rapidly depending on which vein is cut, right? If someone cuts a jugular vein in their neck, they're going to bleed a lot quicker than if they cut a vein in their hand, right? Let's keep that in mind. And then does not spurt. These are easier to manage. Direct pressure. You will use direct pressure. We'll talk a bit about it here in a second, but that is going to work for about 85% of all of the bleeding you're going to encounter. Gloved hand, a little bandage, hold pressure on for about a minute. You'll be surprised how quickly that works. Okay, arterial bleeding, do you think pressure is going to be our go-to every time with this? Is it realistically going to stop? No. Does anyone know what we're going to do? Yeah, very good. We're going to put a tourniquet on, which we'll talk about here in a bit. Okay, so clotting. So bleeding tends to stop rather quickly, usually within about 10 minutes, just depending on, once again, the vein or what vessel we're talking about. When skin is broken, blood flows rapidly. Makes sense also. We have a lot of really small arterioles, venules all over our body, right? So depending if we, has anyone ever seen a degloving injury before or heard of that? Where they basically rip the skin off of their hand or foot. Looks like a glove. There's a lot of vessels exposed at that point, okay? So the likelihood of it bleeding is pretty high, pretty quickly too, pretty high. Now the cut end of the vessel will begin to narrow, reducing the amount of blood, right? So we have that constriction. That's the body's attempt at controlling its own bleeding. You'll have the vessels constrict at the end where things are bleeding in hopes of essentially rubber banding that shut. Does it always work? Definitely not, but it's a good natural reaction we have to it. Once we have that closed down, we've tried basically internally tourniqueting, for lack of a better term. That's when the clotting will start to take place. We're slowing it up, we're binding it, so blood has to kind of stop and then allowing that clot process to begin. Okay, the bleeding will not stop though if that clot does not form. We have to form a blood clot. Blood clots do us a lot of good, they do us a lot of bad as well. Keep that in mind. Questions so far on this? What is the 2 cells responsible for forming a clot in our blood? Platelets. What's the other one? The white blood cells? Red blood cells. Remember, they make the red blood cells sticky. Your scabs are brown, right? Yeah. So, external bleeding, right? Continuing on. We have capillary bleeding. So capillary bleeding is more of like an ooze, right? So dark red oozes steadily but slowly. I always think about it, there's capillary, yeah. So capillary bleeding, there's your paper cuts, right? You paper cut and you can see that line of blood start to form and it just slowly oozes out. It's not venous, so it's not running, right? Depending on the size. If we cut the vein in our upper arm, we're gonna have a good amount of blood moving down the arm, right? But then the last one, arterial, once again, spurting, bright red. That's going to be a big takeaway from today. From this lecture, the big takeaway, arterial bleeding, spurting, bright red. Venous bleeding is flowing, dark red. You want to be able to recognize and identify that because it's going to change your treatment plan, right? If it's arterial, maybe we just jump to a tourniquet pretty quickly. We already know we're not going to be able to control it with pressure, right? Flip side, venous, right? Maybe we attempt pressure first. Let's just see if we get this under control. Yeah?
So there are instances where you would tourniquet a venous?
Sometimes, depending on if you can't get it controlled, right? But that's where factors come in of like, are they on a blood thinner? Is there some sort of disorder we gotta know? Chris was actually just telling a story to me the other day about he tourniqueted a hand injury. A person cut their finger with a knife or something. And it was just a small little cut, but it would not stop bleeding, right? So you just never know. This is where if what we're doing is not working, think of it as like a tiered system. Start low, end high. We can always start with pressure. We're gonna end with a tourniquet if we have to. Right? So even with venous bleeding, if we try pressure and it's not working, we might have to jump to a tourniquet. It really just depends on the situation. Okay? Good question. Any other questions? Okay. Okay, so hemophilia, we kind of talked about it. Patient lacks blood clotting factors. Bleeding may occur spontaneously with these people. Now, all injuries for these folks are serious. None of them are really trivial just because they don't have the ability to clot. If they don't have the ability to clot, they don't have the ability to stop their own bleeding, okay? These are gonna be immediate transports. Now, do you think we can just look at somebody and be like, hemophiliac? No, we gotta ask questions. We gotta ask good questions. I can tell you hemophiliacs are typically male. Reason being is that it is an a Y-carried gene. No, it's an X-carried gene, I apologize. It's an X-carried gene. Do you guys ever do those Punnett squares when you're in like 7th grade science, 8th grade science, right? XX chromosome, XY chromosome, female to male. With the XX, so say mother's a carrier of hemophilia. So her X that she's providing to the baby is gonna have that hemophiliac gene on it. But if mom or if dad produces another X and they have a daughter, because only one of the X's is involved, they're not going to be a hemophiliac, but they'll be a carrier. Vice versa, mom produces the X because that's the only one that she has to give, and dad produces a Y. Well, their only X chromosome at that point will have a hemophiliac gene on it. They will become a hemophiliac. So typically males. Not to say it's impossible for females, right? If dad is also a hemophiliac and mom happens to be a carrier and they both give an X, sure, but just not as likely, okay? Questions on hemophilia? We'll talk more about this later too. Cool? Moving on then. So internal bleeding can be very serious, not easy to detect immediately. Okay, and I'll tell you a go-to sign here in a bit. But injury or damage to internal organs commonly results in extensive internal bleeding. Can we put pressure on this? Can we tourniquet this? No, right? Oh, let's get to this point ahead. If somebody is bleeding super bad from their head and we can't control it with pressure, do we move to a tourniquet? On the neck? No, right? Okay, I just got to get it out there really quick. Same thing, we don't take blood pressures on people's neck. I've had to explain that to a few folks. What happens if you have something around your neck, right? Just keep that in mind. We're not going to tourniquet the neck ever. But going back to this, right? So extensive bleeding, and we'll talk more about it next week. Abdominal injuries in particular, depending on the type of organ involved, is going to dictate bleeding or infection risk, right? Hollow versus a solid organ, but we'll talk about it. And then can cause hypovolemic shock. So a quick, easy takeaway. If we go to a traumatic scenario, dispatch to a bicycle wreck, handlebars hit the kid in the stomach. If we show up and we see a distended tummy, what's a distended stomach look like? Yeah, kind of like they're bloated up, right? If they are bloated up and they're having pain kind of throughout, that's a good indicator they're probably bleeding internally. If not bleeding internally, they have an organ injury, right? In which case, can we tell the difference if they're bleeding at that point or not? No, right? So this is where kind of get ahead of things. Maybe we can start transport a little sooner, okay? Questions on that at all? Okay, so possible conditions, because not everything is going to be traumatic, right? There are some things that medically can induce bleeding internally. One of them being stomach ulcers. Inside of our stomach, we have a mucus lining. It stops the acid from touching the organ straight away, because obviously we don't want to burn holes in our stomach. Well, when people have ulcers, they basically eroded a section of that mucus away. So now that stomach acid is touching the stomach organ itself, and that will cause bleeding, right? There's also, that can happen anywhere in the bowel system, not really from acid, but you can have bleeding in the lower GI and your intestines as well. That can be spontaneous. A lacerated liver is a big one. Can someone tell me which quadrant their liver lives in their abdomen? Upper right. Yeah, upper right. Easy way to remember it. Liver has spleen has an L in it. Liver has an R in it, right? Now you're thinking, wait, liver has an L too. Spleen doesn't have an R in it, so here we are, right? So spleen's on the left side, there's an L. Liver's on the right side, there's an R, okay? Keep that in mind, upper side. Both of those are bleeders. They're solid organs. If we talk about has anyone ever seen a liver before? They're pretty big, right? Big organs. You run the risk of big bleeding. Bigger the organ, the bigger they'll bleed, okay? And a ruptured spleen, not to be trifled with either, that is one that does kill people pretty, I don't want to say super commonly, but it can for sure. And then broken bones, we kind of talked about it. Bones bleed as well. Does anyone know what our bone marrows make? Red blood cells. If they make red blood cells, it would just stand to reason that they can bleed also, right? And we already talked about the femur and the pelvis, right? We can lose a good amount of blood just from our bones alone. That's not even including the tissue damage that's going to happen. Say I have an open femur fracture, goes through the skin. Now the skin's bleeding, the muscle's bleeding, and the bone's bleeding. Okay, keep that in mind. Questions on any of this stuff at all? Okay. So MOIs for internal bleeding, typically a high energy MOI, right? So should increase your index of suspicion for a serious unseen injury. And I think that's just common sense, right? If we think about it, think about dispatch notes. If you're dispatched to, there's a fender bender, someone just rear-ended somebody. Yeah, sure, there could be severe damage depending on the speed, but then your whole thought process will change if you see in the call notes, patient ejected from vehicle. You're already thinking this is gonna be worse, right? This is where you can start putting things ahead of, cart before the horse a little bit and think, well, we're probably gonna get moving fairly quickly, right? Now, internal bleeding is possible whenever the MOI suggests there are severe forces that affect the body. And when we talk about those forces, it's either blunt or penetrating, right? Penetrating, getting stabbed, blunt, getting hit, right? Think baseball bat versus knife. Okay, now blunt trauma can be pretty intense and can cause open injuries to the extent that it looks like penetrating trauma. I'm not going to tell it right now, but I got a really good story for you on that same thing. I'll talk about it next week with head injuries, okay? But blunt trauma can be a force for sure, force to be reckoned with. So don't just think, oh, they just got hit with something. They can still have penetrating damage because of it. One of the first stabbing victims I ever went to got stabbed in the tailbone by a broom handle. They unscrewed the broom. It was one of those metal handles. Guy got caught cheating on his girlfriend. Girlfriend caught him in the shower and jabbed him with the broom handle. And he learned his lesson, punched a good circle right into his back. But yeah, you just never know, right? Blunt can mean a few different things. That's just the factor that's kind of moving towards it. Also, yeah, be careful if you're going to be in the shower and that's the choice you make. Decap BTLS, have you guys gone over this yet? Okay, know this one. There's a few mnemonics you're really gonna need to burn into your brain. Decap BTLS is one of them, okay? This is the one that when you're doing your secondary assessment on Mr. Mannequin here, Johnny Human, when you're doing your assessment on him, we're gonna ask you, what are you looking for? And you're gonna say decap BTLS, and the proctor's gonna say, cool, what is that? And then you're gonna rattle off this here list, and they're gonna say, cool, you don't gotta say it again, you may proceed, right? So make sure you know this one. This is a good one for trauma, okay? Because depending on which type of injury we're dealing with is gonna dictate the kind of care we're gonna provide, right? An abrasion's like road rash. Am I gonna throw a tourniquet on a road rash? Not likely, right? Not impossible, but not likely. So just keep that in mind. Things are gonna change just based on the type of injury we're seeing. Is anybody currently writing this down? Okay, I'll wait a second. You're writing it, or you wrote it? That works just fine for me. Good, good, okay. Moving forward. So NOI, what's NOI stand for? Nature of illness, right? So are we talking trauma? No, right? Nature is more medical. Mechanism is gonna be more trauma, okay? But there are some natures, right? So internal bleeding is not always caused by trauma, with some of the non-traumatic causes being bleeding ulcers, bleeding from the colon, ruptured ectopic pregnancy. Can someone tell me what an ectopic pregnancy is? Just curious if anyone knows it. What was it?
Formation outside of the uterus.
Yeah, usually in the fallopian tube, right? Well, that tube is not as big as the uterus itself. So if as that baby starts to grow, it's going to run the risk of popping that, which is now the zygote, the fertilized cells, will not survive that. They just won't. There's nowhere to incubate them. And on top of it, you run the risk of mom bleeding to death internally, right? Which we'll talk all about that later. And then aneurysms. Aneurysms is like a weak spot on an artery. So think about it as like if we have 3 layers that make up all of our arteries, where we've worn away, I'm really glossing over this, but we've worn away 2 of them to the point that we're now starting to bulge one section. Kind of like a basketball. Have you ever seen a basketball that the bladder bulges through on the inside? It's that same thing. We have that bulge now happening on an artery. It's a thin spot, which means it has a high likelihood of rupture. And if that ruptures, it's tied to an artery, things can go south really bad. One that we're going to spend a lot of time talking about is aortic aneurysms, because your aorta is the biggest artery you have in your body. If we have a thin spot on the wall there, we're on a good chance that popping and then bleeding to death internally, usually fairly quickly, okay? Questions on these at all? Okay. So some signs and symptoms of internal bleeding. So pain is going to be the most common. Blood is an irritant, okay? Blood is not designed to be anywhere else in our body besides in the vessels or where it's supposed to be with the cells. Has anyone ever had a bloody nose? This is a weird thing that all kids seem to have done. They had a bloody nose in class, but they didn't want to stand up and be the weird kid to go to the bathroom, so they just swallowed all that blood instead. If you haven't, then I'm sorry, I'm a weird kid. But yeah, it'll make you throw up, by the way, if you haven't put that together. You will throw up because it's burning in your stomach. And if you didn't throw up, you didn't drink enough blood, coward. Yeah, blood will make you puke, right? And it's going to cause the same irritation throughout the stomach, through the cavity, so it's going to be painful, okay? We might see swelling in the area of bleeding if we're talking about something like the arm, or even if we have like I'm bleeding into my thigh, you might see that area start to swell because blood is filling the area, making it bigger, warmer, and redder. We talked about distension, right? So we'll see that distension in the abdomen if there's going to be some sort of internal bleeding there. Dyspnea, tachycardia, hypotension. What do these things kind of sound like if we're talking shock?
Difficulty breathing.
Difficulty breathing? Well, sorry, all of these together. If we were to say like what segment of shock are they likely going into if we see these three symptoms, what segment would they be in? Huh? I'm thinking compensated is where I'm going, right? Compensated shock. Pressure's dropping, heart rate goes up, heart's trying to compensate for the lack of volume, right? Quantity over quality in some moments, okay? Hematoma, that's gonna be a mass made of blood, right? So this is, I deal with this, or I've fielded this question a few times, right? What's a contusion? Can someone tell me what a contusion is?
Bone that breaks.
No, not quite.
Bruise.
A bruise, yeah, contusion's a bruise, right? Well, hematoma is also a bruise, right? If we break it down from med term, oma is mass, hemato is blood. So anyone ever had a bruise where there's that hard spot at the bottom and it hurts really bad when you push on that one? That's a hematoma, right? That mass you're feeling is the toma there. And then bruising in general, right? So just regular old bruising, contusions. You might see bleeding from the body opening or from any body opening, right? If you're stabbed in the stomach, likely you're gonna see bleeding coming from that stomach. What does hematemesis mean? What?
Vomiting.
Vomiting blood. Yeah, hematemesis is vomiting blood. Very good. What about melena? Can someone tell me that one?
Black.
It's black.
Tarry stool.
Bingo. Melena is black tarry stool. We see this with GI bleeds. It's digested blood. You will be looking in people's toilets after they've used them. Sometimes you'll be standing next to people while they're using them. What a fun job you signed up for, huh? But yeah, so pain, tenderness, bruising, guarding, or swelling, we could see all of those. When it comes to guarding, I've heard a few different definitions of it, and we'll talk about it a little bit more with abdominal next week. But I've heard guarding is, you know, if you're in pain and someone goes to touch you, you kind of tense up, you guard it with your flex your muscles, right? Then also I've heard guarding if someone's like, I hurt my stomach and they're holding it, that could be guarding, but anything stopping them from another person from touching them, right, or causing pain. Broken ribs could be a sign, maybe crepitus in the ribs, maybe we'll talk about flail segments next week. If there's bruising over the lower part of the chest, right, we have blood now pooling in that area, okay? Rigid distended abdomen, I think we've touched on that one a few times already, okay? So for our hypoperfusion, what's another word for hypoperfusion?
Shock.
Shock, right? Shock is hypoperfusion. We are not getting cells or matching cellular demand. But what we might see, some changes in mental status. Their brain's not getting enough blood, right? So if their brain's not getting enough blood, the cells aren't being fed well enough, okay? We might have weakness, faintness, dizziness on standing. Has anyone ever stood up too fast and they see the tunnel close and they think it's the big one finally and it's not, right? That's gonna be that because your blood is not getting to your brain. You stood up so fast you basically use gravity against yourself. Okay, you might see changes in skin color, pallor or pale, right?
Sorry, I'm just coming to see if you have a red pen on my knee.
I don't, I know of, but okay. So blood does a couple of interesting things for our skin. Our blood gives us color and temperature, right? That flushed look, that kind of pinked up look, or that warm, that's all blood. That's blood supply. Sorry, I told you. I have a red color pencil in mine.
I know, I already read it.
Oh.
Just reading it to me.
Perfect.
I didn't take it.
Allegedly. Anyway, later signs of hypoperfusion, right? So we're getting to the point where they've been bleeding for a while. They're going to get tachycardic. That heart rate's going up. They're starting to compensate. Once again, weakness, fainting, dizziness at rest. They might be thirsty. Might see nausea, vomiting associated. Very common sign is cold, clammy skin. Cold, moist skin. That's a pretty standard presentation for people who their body's not working right. Something's not functioning correctly. Okay. Late signs, shallow, rapid breathing, right? They're starting to circle the drain. They've got dull eyes. Their pupils are starting to dilate. Fun fact, when people die, their pupils will dilate open. It's called fixed dilated, okay? They don't move. Cap refill might be more than 2 seconds in infants and children. How can we test cap refill? Yeah, right? If we pinch the finger and it turns white, it blanches, and then we want it to be returning to that pink color in under 2 seconds, okay? That's most people. Weak, rapid, thready pulse, decreasing blood pressures. altered level of consciousness, right? They might not be super awake, super with it. All potentials. I wish I could tell you that you'll see one thing every single time. You won't, right? It's all circumstantial, all based on the situation at hand. You more so have to have the ability to cast a wide net and understand, okay, based on these three things, it could be this or this, okay? Questions on that at all? Okay, I'm gonna skip through the scene size up, primary assessment, secondary stuff, because we're running low on time, so bear with me. Chris talked about shock for too long. Sorry about it, not my fault. But you can blame me if you want. Okay, so what does our care look like, right? Always follow standard precautions. So our gloves, eye protection, possibly a mask or a gown. I'm not gonna get on my high horse about masks right now. Make sure the patient has an open airway, breathing adequately, high flow oxygen, right? We're trying to match perfusion or increase perfusion. And then control obvious life-threatening bleeding as quickly as possible. Is arterial bleeding life-threatening bleeding? Can venous bleeding be life-threatening bleeding? Is capillary bleeding likely to be? Not likely. Impossible, depending on if they're hemophiliacs or not, right? That's where we just don't know, but not likely. Okay, good. So for our methods, right, direct even pressure and elevation, use gravity to your advantage. If I cut my hand off, well, that's too extreme. If I cut my hand, right, we can put pressure and we could even put it up. By putting it up, we're trying to get gravity to pull the blood down, right? Use gravity to our advantage there. Pressure dressing and splinting. Splinting is a great one for controlling bleeding. If our bones bleed and we splint them and get them back where they should be, it's a good one to get it controlled, right? A good way to get it controlled. Tourniquets, we'll talk more about those in a second. Hemostatic dressing, that's not common around this area. Other agencies around the country do carry it. Do I have any military guys in here or gals? I'm sure you guys have seen hemostatic stuff before, right? The quick clot powders and things like that. They're just chemical agents that they basically clot faster. They allow the body to clot faster. And the last one is wound packing. Typically we would use that for like puncture, penetration type wounds and not into a cavity, right? If I have a hole in my stomach, do you think it's gonna do any good to fill me with gauze? No, you're causing way more problems. But if I got stabbed in the thigh, yeah, for sure, you could run some gauze down there, and I'll show you guys that next week, okay? Direct pressure. I know I'm moving a little fast. I'm trying to get you out close to on time. Direct pressure, so the most common and effective way to control external bleeding. It works, like I said, about 85% of the time. You will have pretty well controlled it with just pressure and bandaging. Pressure will stop the flow of blood and permits normal coagulation to occur at that point, right? We're trying to essentially crimp those vessels down to slow it down so that the blood can start to clot. Apply pressure with your gloved fingertip or hand over the top of a sterile dressing. Remember, we don't want to touch anything directly with our gloves if we can avoid it, just for infection risk, because fun fact, infection's the #1 killer of people in hospitals, okay? So we don't want to be part of that game. And then hold uninterrupted pressure for at least 5 minutes. The longer you hold it, the higher likelihood you have of controlling it. We'll also talk about next week when we have skills time. I'll show you guys some methods that we can use, okay? Because I have a good one that a flight paramedic taught me for the junction of the neck, but I'll talk about it next week. For pressure dressings, firmly wrap a sterile, self-adhering roller bandage to the entire wound. I will show you that as well. We typically use what's called an Israeli bandage. Not super common around the country, I've come to find, but they work wonders. My favorite piece of equipment on an ambulance. But you're gonna stretch the band tight, control the bleeding with that, and then once that's on, we're not removing it. We don't remove our pressure dressings, okay? If we're bleeding through it and it's not working, that's a different situation. But if it controls bleeding, if it ain't broke, don't fix it, okay? And then a tourniquet, useful if the bleeding cannot be managed with direct pressure, right? So remember what I said, tiered system. Start low, we can always add more, right? Start with pressure, we can always tourniquet, and if that tourniquet fails, we'll talk. For the hemostatic agents, right, so gauze can be packed into larger wounds when direct pressure is inadequate or application of tourniquets not possible. So these hemostatic dressings, basically impregnated with chemical compounds that slows or stops bleeding by promoting clot formation. These are very specific. Your agency, whatever agency you land at, will know what they use. I did get a piece of pro tip advice. If there's gonna be powders and things like that on there, make sure you're taking into account if you're outside winds, because if you get those powders in your eyes or in your mouth, it can cause some problems, okay? Okay, so tourniquets. We talked about it, right? We have arterial bleeding, or we have bleeding we just cannot control. We got to put a tourniquet on, okay? And I'll show you how to use these next week. Useful if the patient has substantial bleeding from an extremity injury, with several types out there. Really just depends on what field of work you're in, because the police carry different ones than even the ambulances and the fire departments around this area. Okay, but there are different types of commercial devices. Typically, we'll see CAT tourniquets, C-A-T tourniquets. Okay, they also make junctional tourniquets, which allow for the compression of life-threatening bleeding in areas where standard tourniquet is not possible. What if I'm bleeding from my shoulder, like up here? Can I get a tourniquet anywhere there? No, that's where we start to play with those junctionals. Same with like the pelvis, right? The groin region. May be indicative of severe hemorrhage at the junction of the torso with arms and legs. Okay. With tourniquets, the textbook really bothers me when it comes to the description of how we should use these. And there's different ways. I've heard several different methods out there. As long as you remember, we have to be above the injury, right? So if I'm bleeding from my forearm, I cut my hand off, we'll say, bleeding extensively, I'm gonna need a tourniquet. Well, I don't really wanna go here, right? So the typical answers I've seen is high and tight or 2 to 3 inches above the injury. And I think either one would work circumstantially, okay? Let's think about it this way. If I cut my hand off and I put a tourniquet here, is that gonna completely stop all that bleeding? Why not? I see you shaking your head, why not? Oh, yeah, you.
You're right.
I'm talking if I cut my hand off and I put a tourniquet right here, why would that not control the bleeding?
Well, you have 2 bones there.
Bingo, we're good. Yeah, we have 2 bones, right? We have arteries running between those 2 bones. No matter how tight I get that, I'm not gonna be able to crimp those down. So we're gonna go onto the single bone, right? Humerus femur. That's where the high and tight method starts to stick in a little bit better. Now, here's the other thing. Let's say our tourniquet, we put it on, it's as tight as it's possibly gonna go. We cannot get it tighter and they're still bleeding. What are we gonna do? Put another one on. Now, per the textbook, it says adjacent to. Well, what does adjacent mean? Who knows, right? It just means on either side. So typically, if you're gonna go high and tight and you go as high as you can, do we have room to go above that? No, right? This is where I can see both arguments, the 2 to 3 inches or high and tight. If you're gonna go 2 to 3 inches, say I rip off the elbow and we go right here. Let's place another one about 1 inch above the first one, okay? Now let's say I go high and tight from the get-go. I talked to a gentleman who used to be on the TAC med team, the SWAT team medics, and I was asking about this. And he said, well, if we go high and tight and they're still bleeding, we would go about a finger's width below. Okay, but you're gonna need to get a second one on. The reason that we're worried about going below typically is because you can cause what's called compartment syndrome. You can basically stick all that blood there in the middle, and it's gonna cause the muscles to swell. To the point, if it gets bad enough, they'll literally cut your skin to give your muscles room to swell, okay? That's what we're avoiding, but if you can do the inch, that's not enough space for compartment syndrome to really take off. Not impossible, once again. But wherever you land, once again, check your protocols. They might have something way more specific that they're going to want you to know with that.
Are we talking like minutes for compartment syndrome or hours? Like they do that here in the city, right?
It depends on predisposition. I know one gal in particular, she played collegiate soccer, broke her leg, and she started developing compartment syndrome just if she worked too hard after that. So it doesn't necessarily, it depends, unfortunately. It's a it depends answer. But don't worry with tourniquets as far as length. Oh, last thing before I go into this little rabbit hole. Tourniquets, most important thing we have to document. What do you think that is? Time of application, yeah. For a long time, it was taught that tourniquets were essentially, you're dooming that limb. That limb is gonna get cut off, sorry. Well, the longest, don't quote me on it, but one of the longest tourniquet applications was about 7 hours without loss of a limb. So it's not dooming that limb anymore. Science has changed, we've caught up with some stuff. So really, like going back to your question, it just depends on exposure and predisposition to it. Questions on tourniquets? Okay. Splinting, so different types of splints. I'm just gonna kind of fly through these a little bit. But air splinting, so soft splints or pressure splints, right? So these will basically, they're big old bags you'll put over the broken extremity and then you'll inflate them. And then that air pressure inside of that will crimp down the bones and hold everything in place. Can control internal or external bleeding, especially with severe injuries. Depending on your department, you may or may not have these. We didn't carry these ones. Air splints will help immobilize fractures, act like a pressure dressing, and make sure you're only using approved, clean, or disposable valve stems because once again, infection, right? And we also don't want to break our device. Pelvic binders. These are ones that you're going to need to know also. I would make sure you keep these ones in your memory. Pelvic binders, type of splint that may be indicated for suspected closed, unstable pelvic fractures. Typically, we see them with like what we call an open book. So the front of your pelvis is broken, so instead of it being this shape, it's open like a book, right? We want to hold that all together, crimp it in place, stabilize it in place. That way we can hopefully help control the bleeding. You will throw these on to a lot of patients, and we'll talk more about it next week. The biggest issue I normally see is people go too high. Right? Usually they feel the pelvic wings and they go right over the abdomen, but we're worried about where the legs are attached, right? The actual hip joint itself. Okay, bleeding from the nose, ears, and mouth. Several different conditions can cause this. Bear with me, folks, I'm sorry. Skull fractures, facial injuries, right? Cut in the face, bleeding from the face. Sinusitis, infections, use and abuse of nose drops, dried or cracked nasal mucosa, all reasons to get bloody nose. High blood pressure can cause it. Coagulation disorders, right? Clotting disorders can cause it. Digital trauma. What's digital trauma of our nose? Has nothing to do, yeah, nothing to do with computers. People are digging. Yeah. So it can get so bad that you can actually punch holes in your septum if you are really scratching at that. So if you're a nose picker, maybe rethink some life choices. And then cancer is another one. But epistaxis, so that's going to be our nose bleeding. Very common thing. We see it a lot. Uncontrolled epistaxis, we see a lot. Okay. So occasionally it can cause enough blood loss to send a patient into shock, just depending. I've seen people with epistaxis go and have to get their nose cauterized, so they take something hot and burn it shut. Not an uncommon thing. Can usually be controlled by pinching the nostrils, right, or putting that pressure down. Bleeding from the nose or ears following a head injury may indicate a skull fracture. We'll talk more about that next week. May be difficult to control. Do not attempt to stop blood flow. There's nothing we can do to stop bleeding from the ears themselves, right? Loosely cover the bleeding with a sterile gauze pad, apply light compression with a dressing. Typically we'll wrap them with Kerlex gauze and then Co-band, the stretchy, colorful stuff when you donate blood. We'll wrap that around as the pressure. And then we'll talk about halos, but this is a big, important sign. So a target or halo-shaped stain may occur in the dressing if blood or drainage contains cerebrospinal fluid. That's the fluid that cushions our brain, right? So if we have a head injury and we hold gauze up to their ear or their nose, and we see this, that dot of blood, and then can everyone see that kind of yellow color? That's CSF. That means they likely have a skull fracture. We need to go. Trauma is a surgical disease. They need to go to a hospital. There's nothing we can do to help that, okay? For internal bleeding, they're going to need surgery. Once again, surgical disease, nothing we can do with this. Okay, all we can do is recognize potential signs of shock, and then we can get them moving, okay? But usually requires surgery or other hospital procedures. Keep the patient calm, reassured, and still as possible. Remember, the more we move, the more we're circulating blood. So if we can keep them calm and not moving, hopefully the idea is we can slow that bleeding down. High flow oxygen to maintain perfusion, maintain body temperature, that's a big one. To treat for shock, I'll tell you some things I want you to write down here in a moment, and then splint the injured extremity. But to treat for shock, I'll touch on it again next week. We have to lay them, position them supine, cover them with a blanket, give them oxygen, high flow, so 15 liters, non-rebreather, and dry fast. That is our treatment for shock. We can't stop the internal bleeding. Those are the things we have to do. Questions on that at all? That is going to be one that when we ask you in your scenarios, treat for shock, or you're saying, I'm going to treat for shock, we're going to say how. Those are your steps, okay? We'll touch on it.